you're dealing with some of the biggest developmental issues and challenges that we face. Poverty, social exclusion, lack of access to healthcare, lack of agency and empowerment of women, and in this case, girls. Yeah. So you see all the development challenges personalized in one person, and they're hidden. And so that's strengthened our resolve, because also the issue at the heart of this is a medical condition that is mostly treatable.
Today we're sitting down with Dr. Kelechi Ohiri, and we want to hear more about NHIA and the path forward in the coming year. And one of them being to expand health insurance coverage. So thank you for agreeing to speak to us this morning.
Thank you for having me.
Tell us a bit about your goal in the coming year. We hear you have this ambitious target to increase health insurance coverage. One of the populations we often hear about that is difficult to access is the informal sector. So what and how is NHIA working to extend health coverage to these individuals and ensuring financial protection for them?
Excellent question. I think you hit the nail on the head. If we look at the history of and the evolution of health insurance in Nigeria, let's say we started from the low-hanging fruits of working with the formal sector. So it was a scheme that was, one, voluntary, and secondly, focused initially on government workers at the federal level, and then began to include the organized private sector. These are highly formalized, parts of the economy. It's easy to get premiums paid through deductions or contributions from people's salaries. It's easier to track. It's easy. And then when we got to a point where we maxed out on those, we entered a period of stagnation, where health insurance coverage was, I think, between 3 to 4%, and it just continued. It was hard to do anything else. And in spite of many advocacy attempts, the numbers didn't increase. But the NHIA Act of 2022 was the game changer, and hence the optimism that we can actually do more. Amongst some of the elements of it was, one, the mandatory nature of health insurance, which for the first time health insurance has been made mandatory. The second element to that is that it advocates for government actually covering those who cannot pay. And in many countries, where you see many examples of countries that have advanced towards universal healthcare coverage, there's usually significant public sector financing, especially for those who can't afford it. So when you look at the segment of the Nigerian population, you have those in the formal sector, then you have those who you're trying to cover through the equity programs like the Basic Healthcare Provision Fund. But the vast opportunity lies in the informal sector. And that's where we think there's an opportunity. 3 things have to happen for us to actually realize some of this opportunity. First is the enforcement of the mandate. And that requires a whole of government approach, such that the multiple points of interaction of people and businesses with the government, we try to enforce that. So that will bring in a lot of people into that. I think currently, if you have a company that has 5 or more employees, you're required to insure them. It's good practice to insure your employees beyond just the mandate. But at least that's the first lever. The second lever is that of awareness. There's remarkably low awareness of insurance in general. More so talk less of health insurance. And also our health-seeking behaviors. People don't like to talk about health care. And we have this superstitious belief sometimes that if you go and get health insurance, then you're inviting, trouble to yourself. And also it's easier to say things like it's free care. People can relate to that. So we're trying to explain the mechanics of health insurance is a bit trickier. So a lot of awareness is needed. Educating people about the need for insurance, how insurance works, and it is better to pool your risk and pool your resources than to pay out of pocket when you need care. Now the third thing, which is one that I believe is the most critical, is trust. Rebuilding trust. when you are insured, it has to mean something. It has to mean that when you show up at a hospital and you're covered, that whatever you came for, whatever ailment you came for, one, will be taken care of, and two, you do not have to dip your hands in your pocket and pay the full cost of care. Now, anything that sort of jeopardizes that implicit compact erodes trust in the system. And that's why we're trying to we're scaling up a lot of work we're doing on enforcement, handling complaints, making sure that all the stakeholders that are required to work together to make the enrollee receive the services they paid for are held to account. NHIA hold ourselves to account, the HMOs, and also the providers, so that the enrollee doesn't suffer. And it has to be about the Nigerian citizen, the enrollee. And so in 2024, for instance, we intervened in at least 2,000 cases where 90-something% of them were resolved within the stipulated time. Some are pending for the investigations. And sanctions included things like facilities having to refund the patients for paying for care that was already covered. In some instances, HMOs had to do that because codes weren't given for services that were supposed to be rendered. And that's a journey that we intend to do more of this year. That's something we intend to continue to work on, the enforcement, because that trust has to be rebuilt. Because once that trust is eroded, then I don't see then it limits how far we can go. Now, this is on the awareness and creating trust and mandates. But there are other things we need to work out, because the informal sector is very hard to actually even tax, right? So we need to look at innovative mechanisms for financing, working with, technology companies, working with telcos, looking at payment systems with fintechs. How do we make it easier for people to pay for health insurance? And I think that's one of the things that we're currently working on, so that at the point of decision, when you're convinced you want insurance, then what's the next step? It should be easier, it should be accessible, and the payment mechanism should adapt to our realities. One of the books that influenced me a lot in my development journey was a book called Fortune at the Bottom of the Pyramid. It was written by, I believe it was a Michigan professor. His last name was Prahalat. And one of the examples that stuck with me was the example of detergents. I mean, most of us grew up buying detergents like Omo, etc. And it was, you had to buy a box of Omo, like a carton of it, right? And it was expensive. The poor don't shop that way, because the informal sector, they get their money daily.
Exactly.
And so what happened was that many people devised a method of taking the carton of detergent and pouring it into small nylon bags, right? And so that's what people were selling. Because the consumer behavior for those at the bottom of the pyramid was such that they wanted to buy only a little bit of it and afford it, but then they couldn't go to the supermarket and buy the big sachet. And eventually, the companies that manufactured Omo cotton, and they began to manufacture little sachets of that. So that's where innovation and the businesses are adapting to the local context. Now, the concept of insurance, of health insurance that we have applied, it's something largely borrowed in its current form from social health insurance that we have in Europe and private health insurance from the US with health maintenance organizations. We have to reform and find a way that would fit the informal nature of our economy, the way people spend, the way people engage the health sector, but also the way people earn income, and the way to put all the principles and the guardrails around that. And I believe that's what the challenge is. And if we can crack that, then I believe we'll be able to meet people at the point of their needs, so that we don't have to force them to fit into an existing model, but we adapt the model to the Nigerian citizen who needs to access health insurance.
Thank you. That's very clear in terms of how do you retrofit an existing model to fit the realities of our country, and understanding that informal sector is large and easy to find and measure, but they are one of the many disparate, vulnerable, or harder to reach groups. I notice also that another group that you seem to have a focus to reach that people don't often think about, often overlooked, are women. One of them being women who have vaginal fistula. They are a group that's often stigmatized in society and left unattended to and don't have access to healthcare often. You seem to have focused or have a program to reach these women. What has made you focus on these vulnerable women and providing them with care when often they are not the ones people think about or focus on in terms of providing health insurance to?
I mean, very, very good question. One of the pillars of what NHIA is trying to do is, the equity pillar. Because every country has to map its path towards universal coverage. We don't want our path to be such that first the wealthy, and then those in the middle class and the formal sectors are those that have access, and then it begins to trickle down to the poor. We want a journey where we do our best to ensure that no one is left behind. When the coordinating minister for health and social welfare said maternal mortality was a priority, we all rallied around that because Nigeria has some of the worst maternal mortality indicators in the world. And that meant we had to do something drastic about it. But there's also the concept of vulnerability. Part of the NHIA Act was introducing vulnerable groups. And one of the things I did was really reflect. It gave examples of vulnerable groups, those with income poverty, those who are displaced, the poor elderly, the disabled, etc. But I began to reflect on our country and our situation and see what are the groups of vulnerable people that we may have left out, people who are hidden from society. And when you look at the nexus of the burden of maternal health and poverty and vulnerability, I think no one epitomizes that as much as the woman with obstetric fistula. First, they've gone through the journey of childbirth. And this is a complication that arises largely from that. There are other causes, but most of the cases we see are caused, by prolonged obstructed labor. They tend to be very young. They tend to be ostracized, stigmatized, and they're poor. So it's almost like, when you see a woman with fistula, you don't need to ask many questions around whether she's poor, whether she's vulnerable. I mean, it's almost, it's almost taken for granted, right? And so that was what we began to see. When you visit or speak to a woman with fistula, you're dealing with some of the biggest developmental issues and challenges that we face. Poverty, social exclusion, lack of access to healthcare, lack of agency and empowerment of women, and in this case, girls. So you see all the development challenges personalized in one person, and they're hidden. And so that's strengthened our resolve, because also the issue at the heart of this is a medical condition that is mostly treatable. And so what we were trying to do is, if you ask why aren't they being treated, is largely because they lack financial access to getting definitive treatment in hospitals. And so when we ran the numbers and looked at how many cases we were seeing by the obstetric fistula centers across the country, the numbers were not alarmingly large. And so we felt there was a moral imperative to do something about this. We focus on mortality, rightly so, but also there's a lot of suffering and morbidity that comes with this. And so we decided to take it on, and that's how we started and began to design a program, and I can talk more about the program if we have time for it. But that was really the rationale for it.
From what you were saying, it's very true, because most of these young girls, which often is the case, fistula is a consequence of childbirth.
Yeah.
And that has a detrimental impact on their longer term health outcomes, and also access to education if they may still be in school, because many of them are still young. So really reducing maternal and neonatal mortality seems to be is a focus of the current administration's 4-point agenda. Financial barriers often impact a woman's decision to seek care, but also when she's in childbirth, to even go to a health facility, one of the first delays. So how is NHIA making that financial barrier not a limitation when a woman seeks care or needs emergency obstetric care when she's about to give birth?
One of the things that we're trying to reduce is something called health poverty, really. And health poverty is really one, you think about it two ways. One, sometimes people are too poor to afford healthcare, and so they lack access to healthcare. But then in some cases, you have people who can pay, but are one catastrophic ailment away from being plunged into poverty. So there's just a level of vulnerability. Now, when we started looking at financial access for all Nigerians, and the minister and the government outlined reducing maternal mortality as a priority, we felt we had a role to play, particularly when you look at the third delay, which is the delay in actually getting care when a woman actually shows up at a facility. Many of us heard many cases where a woman will show up, she doesn't have the money to pay, and she gets turned back, or she gets bounced around from hospital to hospital until the hospital that's maybe on paper provides free care, then accepts her. And then another journey of, not having the commodities and the supplies and borrowing from another patient or asking the relatives to deposit money here. All those delays could be fatal, right? Now, the hospitals are only trying to sort of protect their financial situations, because if they did that for everybody, then they probably would go under financially. Yeah. So it got to this sort of low-level equilibrium that was at play. So what we're trying to do is say this, that if a woman who can't afford it, well, first of all, when the woman shows up and is in that state of acute vulnerability, again, the key word here, it will keep going back to is vulnerability. And so this is a form of acute vulnerability. You're vulnerable for the 48-hour period, wherein if you do not have a specific specialized intervention, you might die. And that is not the time to start debating as to whether or not the woman is poor enough or rich enough to pay, etc. We're saying address, the emergency, the maternal emergency, and then figure out if she can't pay, fine, bill us, we'll pay for it. What we're trying to do here is reduce that third delay, so that it's not at that point that we start, worrying about that. Also give the hospital the confidence that go ahead and treat. And even if the family cannot pay, there's a guarantee from NHIA that will be paid for. And of course, now when we say that, naturally people start thinking about abuse and moral hazard and all that. And I tell people, I doubt if a woman wants to go through postpartum hemorrhage or elevated blood pressure, eclampsia or pre-eclampsia, just to access free care. So this focuses on emergency interventions at that period. And we identified what the leading causes of maternal mortality are. And we are costing it so that we even pay as a bundled package of services, and we are addressing those. Now, to actually ground our concept, we had a small advisory group, professors of obstetrics and gynecology, one from the Society of Obstetricians, one from the chair of the Committee of Medical Directors, Professor Membasi, and Professor Galadanchi, who's a researcher, and a professor of obstetric oncology, and we tested the model and decided to start with, a pilot. And we did that in Kano with 3 hospitals that had most of the referrals. And that's where we started seeing some of the results, and we're getting very good results from there. Now, and then we began to scale up. So right now about 52 federal tertiary hospitals have signed MOUs with the NHIA, because again, we're a financing entity, so the right structures have to be put in place. And then all the states in the country have been written to. They've not only sent all the data on mortality and childbirth, they are also now sending their expressions of interest. About 2/3 of them have already expressed interest in being part of the program, have suggested facilities where we're running the numbers, because we want to start with where women actually go to. So the high volume and then high mortality facilities are where we'll start to, before we then continue to roll out to the rest of the country. So the intervention is this, similar to what we're doing with VVF. Address the emergency or the condition the woman shows up with, counsel on family planning, and then enroll them in insurance after that, so that subsequent health needs are covered, because we still believe insurance is the best way for financial protection in Nigeria, given the system we have. So we're not just addressing the issue, we're also ensuring that they get insured, and we sign them up through the Vulnerable Group Fund of the Basic Healthcare Provision Fund, and where those resources are available, NHIA makes resources available for that coverage, and so that it's also consistent with our mandate in terms of what we do. Family planning, because it's critical. For women with VVF, I mean, we've seen cases where they go back into their households and communities, and it comes back again. And they come back again with another VVF. So giving that an opportunity for their bodies to heal properly, and for them not to get pregnant again immediately, at least space it, is a critical element of that, as of course advised by the experts, and that's financed. Then for those in the CMONC program, the same thing, counsel them on the need to space it. There was a trip I made to a primary healthcare center. I will not say where, and it was quite interesting, because almost 60-70% of the women there that came for ANC were nursing a child that was not yet a year old. And there were some others who had, were grand multiples. So they've had 6, 7, 8 children. So the ones that were a bit older were there. And then I also stopped by the family planning clinic in that place, and I saw that they didn't have a lot of the commodities. And when the women were asked, of course they wanted it. So there's an unmet need. And so we're saying, at least be counseled on it, and then know what your options are, and then choose accordingly. And then in terms of insurance, one of the things that NHIA is also doing is ensure that becomes part of the benefit package, because it is important, because it protects the woman's life. And so those are the approaches. But our approach is really on the financing part. Solve the index problem, because we have an emergency in our hands. Make sure they have, counseling on, what they need in terms of reproductive health, etc. And then make sure they have access to a robust insurance program and coverage. So because a woman is more than just her reproductive health needs, so they can have malaria, they can have anything else, they can go for preventive care. And that's why we enroll them in insurance afterwards.
I mean, it's almost like taking a life cycle approach. You meet her when she's young, but then there are many stages through which she will need to seek care, and getting her at that stage when she's giving birth, you can now follow her and her children through those different life stages. So it makes perfect sense. I'm going to switch gears a bit now, because the end goal for NHIA is ultimately to push up enrollment on health insurance schemes. And efficiencies in terms of improving health delivery is, of course, critically important. And technology and the use of data analytics can really play an important role in improving some of its efficiencies. So For you at NHIA, how are you utilizing some of these digital tools to expand health insurance coverage and track service delivery and ensure accountability for services delivered by the healthcare facilities that are signed on to health insurance?
Yeah, I mean, I feel that it's critical for us. It's one of the enabler strategies that we highlighted. When I came into this role, there have been a lot of effort put into something called NHIA. And the aim and the objective was to look at a way to integrate, all the various health insurance schemes into one platform, where as a regulator, we would have more visibility to what is going on, but also then we'll also track quality and health outcomes. Now that's still in the nascent stage, and one of the things we're doing is really looking at, one, how do we leverage technology for enrollment? And we're looking forward to a point where, people can self-enroll and you don't have to come to an NHIA center to enroll in insurance.
Yeah.
And by mid this year, you'll be able to pick up your phone and enroll in health insurance, and that's what we're working towards. Beyond that, we're also looking at, how we manage claims, moving away from manual, review and claims management to having a platform that is more, digitized in terms of what we do. And then the third thing that we're looking at doing is integrating that. I mean, for every bank account that is opened in Nigeria, the central bank is aware.
Yes.
Right? And so for every Nigerian that is enrolled, whether it's an NHIA scheme or a private scheme or a state scheme, as a regulator, we need to know that person needs to have an identity, and that person needs to have a unique insurance number that the regulator can ensure that services are being provided to them. And so those are the three things that we want to make sure that we do. On the quality front for our schemes, we've started many things. We've partnered with Farm Access Safe Care on digitizing our accrediting approach, so that when we accredit facilities, it's not done manually anymore, but it's done using digital tools, because it lends itself to better analytics, to better monitoring as well. So it makes us more responsive to the facilities. So we're on that digital journey, and that's the only way we can actually go to scale in terms of what we're doing. So early days, we're not yet at a point of looking at things like artificial intelligence and all that, but it's something that we're going to come to.
Okay, thank you. So Dr. Ohiri, my final question is more now understanding your reflections and your leadership journey as Director General of NHIA. What personally motivates you in your work? And how do you vision a future for health insurance in Nigeria, expanding coverage for all citizens?
So in terms of leadership, I always say that I reflect and I think that if people knew what it took, what it required to be a leader, many of us would run away from it. Because it's about service, really. Service to humanity. It's often sacrificial because it requires a lot from you. It stretches every resource you have as a person. So it's not easy, particularly in the context in which we're working. It's easier in certain climes where it's almost linear, right? You apply certain principles and you see results. Here, it's very adaptive, and it's almost like playing 3D chess all the time. And another analogy would be a steeplechase marathon. But sometimes like when I visit a facility and you see the impact of what you're doing, nothing beats that. Because fundamentally, I believe that with all we have, all we've been blessed with, all we've been given, it's not for self-service. It's really in the service of others. This job and this role provides that opportunity to be of service to others for something that matters so much: healthcare and financial protection for them. So for the NHIA, I would like to see a situation where Nigerians don't have to, will go to bed or feel comfortable knowing that they don't have to worry about how they'll pay for healthcare should they be ill. But also beyond that, people should be comfortable getting screened, taking preventive mechanisms, knowing that a diagnosis doesn't imply a death sentence because you cannot afford it. I would like NHIA to be seen, and health insurance to be seen as that mechanism for which that has been achieved. So the NHIA to be that catalyst for universal health coverage and for improving access to care for all Nigerians, so that we don't have to keep leaving the country to get healthcare. 2, people invest more in Nigeria knowing that there is a payer that is able to pay for people's healthcare. 3, that we are contributing to moving away from a purely curative-based model to designing a system that incentivizes primary care, incentivizes prevention, incentivizes good quality care, because ultimately we want people to be healthier and not sicker. And if we can contribute a little bit to that, then we've come a long way. And if we can begin to reposition the organization to doing more of that, then I think, it'll have been time well spent in this role.
Okay, brilliant. Thank you very much, Ohiri, for granting us this interview. And best wishes in the year ahead.
Thank you. Thank you
very much.